gastric reflux. So 28-year-old female, sorry. Head injury, 2245 by air. Okay, great, thank you. Bye. It's a vehicle occupant that's fell from the vehicle, going at an unknown speed.
Cat 2 head injury, 2245. Yeah, all right.
Richard, they've just rang through the heli-med team. Do you want her RSI'd when she arrives?
Yeah, absolutely. Can we get the drugs out? So we've got a young lady who's coming from Wales who's been involved in a road traffic collision. I'm not exactly sure of the full mechanism of what has happened. She's got obvious signs of a head injury. They are flying her directly from Wales to Stoke because we have neurosurgical services here. But they have requested that when she gets here, she will need to be put immediately to sleep. Once we get control of her airway, we can control her breathing to give her brain the best oxygenation and also the best blood flow.
When the patient comes through the door, you don't always know what the diagnosis is. You have to be confident and you've got to make decisions fast. That's why it's a critical decision. That's why it's emergency medicine.
Okay.
So this is Laura, she's 28. Mechanism, she was a vehicle occupant who's thrown out of the moving car. Unknown speed.
Yeah.
Injuries, primarily head, but query other. She had a heart rate of 70 to 80.
Yeah.
And she had a GCS of 6. Any questions?
No, that's it, thank you. Nisha, get in there, do primary. She's not losing that right side as much, though, is she? We're obviously concerned still about the head injury, but we need to make sure we don't have any other injuries that aren't going to be life-threatening and missed. So I've got my anaesthetist there to put them asleep. I've got my trainee in emergency medicine to do the primary survey, so check for any immediate injuries. And my job as a trauma team leader is to have an overview of everything. BP cuff on her, please.
Could you just lift this on, lovely?
I can hear good bilateral air entry.
Excellent, yeah.
No obvious open wounds. Do we have a blood pressure? Yeah.
Okay, railroaded over. That's a fine. Have a quick listen to the chest, Nisha. No obvious big wounds.
There's pooling blood. Let's get this. I'll try the tube.
Yeah, sorry. Bilateral air entry, thank you.
Air entry, yes.
Excellent.
There's a load of blood in her hair, Rich.
It's a...
Oh, bit of a bulk. Yeah, nice foggy swelling at the back there.
Okay. Hi, it's Richard here. Are we ready to run round with our trauma patient?
It's not been protocol, but yeah, I'll run the red jump now again.
Lovely. Excellent, thank you. Yeah, they're ready. We can rock and roll round. The big injury we need to find out, the most pressing one at the moment, is what the scan of the head shows as to whether there's been any injury in there. That will be the first thing, and then it will also pick up if she's got any other injuries anywhere else. Okay, yeah, everyone ready?
Yeah.
Okay, ready, steady.
Marvellous.
Right, and that's it, yeah. Take it up off to the minute.
Sorry, I meant to call you about this, but it's just all kicked off in there, so. So this is a young girl. GCS has been 6. She's got a blown right pupil, but she's got evidence of a right-sided head injury, so unless it's a contracule injury. With midline shift. Big fracture on that right side as well.
Neurosurgery.
Hi, yeah, it's Richard here again from A&E. We're in CT with that young lady. She has got an acute left-sided extradural.
Okay, no problem. I'll just get this now, okay?
Lovely, thank you. Cheers. Yeah, cheers, mate. She'll need an operation. So the scan shows that she has had a bleed in the skull, which is compressing the brain. The skull is a fixed box, doesn't move, and if you bleed inside it, then the resultant problem is that you squash the brain, and that will eventually kill you. So that needs to have an operation to evacuate that blood from there so it doesn't have any more pressure effect on the brain.
Trauma cases are my passion, and to be able to deliver care to these patients is an absolute privilege. But my part is very small in the whole process of getting these patients the care that they need to do the best we can for all patients that come through our doors is what we are here for.
Can somebody find out for me? Because I've got a bit of a queue.
Hello? Hello? Open your eyes.
Style it.
No, we need a bogey. Yeah.
Okay. We need to make sure she's got some IV access.
High blood pressure, CKD3.
Hello, resource Liz speaking.
Motorcyclist versus car, dislocated ankle with a white foot.
As it's naturally very compromised. Okay. Dr. Hart's going to take the trauma and assess that.
I'm Sophie, I'm one of the doctors. I just need to examine you, alright?
Yeah, okay.
My name's Charlotte, I'm one of the other doctors. I'm going to have a look at your ankle, alright?
Right. I've not got to remember all these names.
No, we're not going to test you, don't worry. Big breath in and out for me. Okay, that's fine. Equal expansion. Being central. Big breath in. Have you got any pain anywhere? It's a bit difficult to tell, but I suspect his foot may have got caught underneath the bike and then dragged. Can you feel me touching your foot at all? Can you feel the orthopedic doctor touching your foot?
I can't feel it.
For me?
So it's quite severe inside. His calcaneum's probably shattered.
I feel someone now touching it.
Charlotte, you can just feel a little bit of sensation now.
Okay.
Aren't we? So you had your hands on,
Yeah.
chest palpated, no tenderness, no pain.
No
Deep breath in and out,
Yeah.
moving arms, shoulders, that sort of stuff. If all that's clear,
Yeah.
that's good, isn't it?
Yeah.
It's
He's
actually
complaining of pain around the back here.
just under there.
Yeah.
I've just been lying funny for
It's not actually got bone. It's 100%, so.
what do I need to do?
You need to just lie still. Nice and slow, folks. Just take the left board out. Ready, steady. Probably do getting some x-rays just to give us some idea of what we're looking at.
Yeah, it's really severe injury in the foot in the middle. It's completely horrible. He's obviously either caught it and it's done, or it's been the first thing that's hit the floor. Like as close to being ripped off, I guess, as it could be. And the fact that he's lost some sensation and the foot looks a bit pale makes us worried that the blood vessels underneath are damaged as well.
Jason, this is quite a serious injury. Okay. The foot is white at the minute and it doesn't seem to have any pulses, which means the blood supply isn't very good to it.
Okay.
I think you need to be aware that this is a potentially limb-threatening injury. Okay. And I want to be straight up with you about that because there's no point in beating around the bush.
Okay.
So we're just going to get some quick x-rays and just see if we can get some idea of what's going on with the bones.
Yeah.
But you're going to need to go to theatre today. Okay.
If anybody wants us to phone you,
My wife should have been informed.
do you want me to ask her to come up?
Is she here?
I don't know if she's here. Do you want me to ask her to come up then?
I don't know whether it'd be too distressing for her, to be honest.
So infection is his biggest risk at the minute, apart from the blood supply and the nerve supply. This is a devastating injury. Yeah, a really devastating injury.
What's okay now?
Jason, we're just having a look at this foot again, sweetheart.
I was going to give him some ketamine if you're happy, yeah?
You'll feel a weird sensation, Jason. So just try and put your foot in a better position.
The ankle bone sort of sits in the ankle like this, and it's come out a bit like that. So it's just trying to straighten it up because that's the blood vessels can run through there, and that can be where they get pinched. So if you actually straighten that up, maybe it releases the blood vessel and then lets the blood flow back to the lower part of the foot and helps with the sensation.
Just hold it there a minute, see what we've got. Hold it there a minute. So this area is all completely white as well until I reduced it, so it's looking much, much better. And around here, his toes are still pretty white, but we've got some venous filling now as well in the foot. So
we're going to aim for second in theatre 22. So I'll take details down now and I'll book him. Great, thanks.
we are worried about is that foot. So injuries are actually not around the ankle, they're further down his foot. When he first came in, the foot was completely white, there was no blood supply, and also he couldn't feel it at all, so that's a really bad sign. This is still a very, very bad situation. The bones are very badly smashed, and this foot might not be reconstructable. Then as soon as there's a theatre free, then we'll be taking him down. He's got everything for him, okay? And if we can salvage that limb, we absolutely will, okay?
That's on sedation, so.
No, I feel like shit.
You do? Alex is here. Love you.
Sorry.
What are you sorry for?
Have I been surgery?
Not been surgery yet, no. You're going in a bit. They're going to get you down as soon as they can.
Right. Oh, we could do without this, couldn't we?
I know. Oh, dog. Pain relief. Oh, dog.
No, stay. Jason?
Yeah?
Hello.
Yeah.
I'm Mr. McFadden. I'm an orthopedic surgeon, broken bone specialist. With these injuries, we can only really work out the extent of the damage by looking inside the wound. And so with you asleep, we've got to make decisions, and we've got to ask your permission to trust us with those with those decisions. The worst case scenario is that we'll find that the foot is actually already dead. So that's the really difficult situation where we would say to you, the best thing for you would be to have the foot off.
Okay.
It's clear that in some situations, even though technically we could put it back together, your leg would work better having an amputation and a false leg.
Okay.
Now, some people can't get their head around that and they just want to keep their leg at all costs.
Yeah.
Some people are all about the function and go, whatever it takes to get me walking better, and can accept that.
Yeah.
Does that make sense?
That makes perfect sense.
And the aim of everything we're doing is to get him back to you doing as much of what he was doing before. Okay.
Thank you. Thanks for your time.
Cool.
I'm just sorting this man out to get a neurosurgeon to come back down. This is a post-cardiac arrest.
Cat 2? Cat 2? Yep. Right, okay. So I need a trauma CT.
To step the other lady down so we've got space.
Show me your tongue. You can do it, David. David.
Real straight pieces. Base of skull fracture, okay. Right. That's a 77-year-old female, fallen top to bottom of the stairs, witness loss of consciousness, clinical base of skull fracture, coming by air, intubated, ventilated at scene. Carnarvon Air Ambulance.
Super. This is a lady who's fallen downstairs, who's got a reduced level of consciousness, who they have put to sleep formally at the scene to protect her as much as possible.
Is that now? Ready, brace, lift. No snags?
No.
Okay, good. This is
Yeah.
Right. This is Jean. She's 77 years old, and around about 11 a.m. this morning, she was in a holiday home, and she fell off the flight of a set of unfamiliar stairs. Witness loss of consciousness. When we arrived, she was a GCS of 10. She's got clinical signs of a base of skull fracture with blood coming out of the right ear, and she's got a closed fracture of the right clavicle.
Okay, last day's roll.
It was 5 minutes ago, just before we landed.
Lovely. Thank you. Okay, Tube, you happy?
Yeah.
Anti CO2?
We're just about to hook onto our
Excellent, good. Yeah, hold the head, and then we'll take out. Okay, one side of the board out. We'll go slightly head up on the bed once we've got the blood pressure and we know what it's doing. Quick set of bloods off as well whilst we're ordering the scan. Okay, so we get the portable vent and monitor ready.
Absolutely, portable vent is already attached.
What's our FiO2 there?
Is 80.
Yeah, it can come down. It's got VO2 of 73, so we can probably come down and chat.
What's the CO2?
CO2 is 3.8.
Yeah, both equal, both reactive. Size 2.
Right, shall we just start slowly walking around there?
A simple fall can have devastating consequences and can be a terminal event for some patients.
Good. Everybody ready? So we'll go on slide, ready, steady, slide.
It's essential that we get that patient to scan. Knowing what's going on allows us to plan for future treatment of the patient.
Mike, can you let the regimen?
And it was a trauma, wasn't it? It's not.
Yeah, so witness fall downstairs, about 11 steps.
So large subarachnoid hemorrhage mainly on the left. So subarachnoid, you will need neurosurgical.
So extensive subarachnoid left side. I've spoken to neurosurgery, they're going to look at the images, but I guess you'll have an ICP, but
yeah.
Just ringing the IT consultant to give them a heads up, probably get a level 3 patient.
But nothing surgical.
It's just extensively light down the left side.
Let's have a look at the scan.
So it's quite extensive.
A lot of blood sitting down there, isn't there? She's got small, probably extradural there.
You just see like some blood extending into the brainstem here as well.
I suspect that's a fracture there.
So just on looking through the recons at the moment, it doesn't look like there's any obvious aneurysm that caused the bleed, so it must look like it's probably all secondary to a fall and traumatic bleeding on the brain.
We know that the CT scan has showed a lot of blood on Jean's brain, but what we don't know is whether she'll wake up. Jean, can you squeeze my fingers? Jean? So nothing at the moment, but as I say, still early days, so we'll wait for a little longer. This vicious hindfoot injury. We'll have a look. If we do go to amputation, I'd really quite like to do one stop, get it done.
He's got that, and then he's got the other wounds on the medial aspect of his heel.
See the wristband?
So you see the whole heel is degloved. Inside there, the talus is spun 180 and the calcaneus is spun 90 degrees, and they're not communicating with each other anymore. We actually seen if dorsalis pedis is there. Okay. Before Charlotte reduced this, the foot was white, implying that that wasn't working.
Yeah.
So, okay, yeah. Right. So, we're all in complete agreement.
Yeah. It's not to reconstruct the foot.
Okay. We're going to go to Bologna and try and do it as a single stage primary closure now. Okay. I'm just going to ring his wife now to let her know. Hi, is that Angela? Angela, it's Mr. McFadden calling from the operating theatre. We've seen that the major blood flow to the sole of his foot has been torn by the injury. And it's been torn in a way that we can't repair it. So what that means is that all the sole of his foot, around the back of his heel, and all of that, the skin is dead. So we think that the best thing is to proceed with the amputation. I'm really sorry. When he wakes up, we'll be able to say to him, there was no choice.
So all this is healthy tissue that we're going to use to cover the bone and use these skin flaps to fashion his stump. I think with these cases you have a mixed kind of feeling with it. We're gonna give him a functional stump, but it would be nicer to have saved his foot if possible. So this will shrink down over the next few months and then have a nice amputation stump which will allow him to function and mobilise quite well.
I knew I was going to get that phone call. I knew. The other phone call I could have got was he'd been killed. And that would have been one of the worst things. So, you know, there is a positive in everything. And that was that positive, that he was here. He was here and he's alive.
I've chatted to your wife, and we took all the dressings down and had a look, and the blood supply to most of the foot was completely destroyed. And there was no doubt with any of us. We were all absolutely certain that we couldn't, despite all the expertise we've got, save the foot. So we decided, you know, having spoken to you about it before, that the safest thing for you would be to go ahead and do what we really all hoped we could avoid, and do an amputation. We've done an amputation through the middle of the leg, the lower leg, at a very good level for being able to get a false leg on. So I'm really hoping that this is your last visit to theatre, which is one a positive bit of relief. We'll chat again tomorrow.
Okay, thanks so much.
Okay.
Good evening, State Resource.
We've got a trauma coming through. This is a 80-something-year-old female, full head injury. Sounds like potentially intracranial bleed. Needs to go for scan. Sounds like full escalation, tuber, neuroprotection. Yeah, it's time critical. So red, standby.
Hello, Lisa. Stephanie speaking.
It might have something to do with a kidney failure as well, I guess.
Yeah.
I have my gentleman's notes run off to...
You wouldn't just run me a BM machine round, would you?
So today we've got a young man. He's developed a very aggressive esophageal cancer. It's the 4th most common cause of cancer death in the United Kingdom. This is Shane's only opportunity to get rid of his cancer. If we don't achieve what we need to achieve by doing the surgery, unfortunately his cancer will escape control of other treatments and bring a premature end to his life. Here he is. Good morning. I'm fine. How are you?
Not too bad, bit nervous.
I just saw your mum and dad.
Yes, they did
outside.
say. Yeah, they did say. My girlfriend's
And
texted
Lisa.
me already. Yeah, she's texted me already
Yeah.
saying she bumped into you.
As you know, big day today, but it's the first step, the first job is to get rid of the cancer, get rid of everything we can see, bring it all back together again and join it up nicely.
Yeah.
So the plan is an operation inside the tum with a few little cuts inside the tummy. Gas goes inside, log instruments go inside, and we do the keyhole. Yeah.
That's right, yeah.
And then, so we'll free up the stomach, make a new tube out of your stomach, and then close all that up. Job done. Turn you on your side. Then we go in between the ribs at the back, towards the right-hand side and to the back. Go between the ribs, collapse the lung, go inside the chest, and then we'll take out the esophagus, all the tissue around the esophagus, and then bring up the tube we've made out of your stomach up into the chest, and join it up to what's left of your esophagus at the top.
Yeah.
Okay? Close it all up, wake you up, bish bash bosh.
Easy as that.
Okay? All in all, it takes about 8 or 9 hours altogether.
Yeah.
Okay, so it's, but you'll be fast asleep. You'll be sound
I
asleep
hope
for
so.
the whole thing. Yeah, you will. Obviously, as we've spoken about, there are some things that can go wrong, a few complications that we need to be aware about. But we'll keep a very close eye on those and hopefully jump on them and deal with them and manage them as we need to. Okay, Chief?
Yeah, I'm all right. Ready to go, I think.
We'll look after you.
Okay.
Okay?
Thank you.
We'll look after you.
one night and I was just eating my tea, and then for some reason I found swallowing like the straw. I took a bite of food and I swallowed it, and it seemed to like as if it got stuck in my chest. Kept doing that, so I went to my doctor and they sent me for an endoscopy, and they found cancer in my esophagus. I was only 41 when I got diagnosed. It was a shock because you don't think of, you know, things like this happening to you, because especially me, I mean, I don't drink, I don't smoke. I keep fit and healthy, I only eat organic food. I go to the gym 5 days a week, you know. It was hard to take. I've got 4 young kids, and it has been quite hard. Yeah, I'm nervous, but it's the best chance I've got.
There we go. And then if I can get you to wander around this way, fair from the floor slightly, well, I'll shut that door.
Trying to get me head around what I'm going to feel like when I wake up. It's the thought of knowing, at least when I am awake, that isn't going to be in my body anymore.
It's a big operation, but it's actually simply one operation made up of lots of little operations. Surgeons call this the operation with 1,000 complications, because we're doing lots of different things, moving things around, joining things together, and there are lots of things that can go wrong. So quiet for handover, please.
Okay, so this is Toby. He was wakeboarding at the Delamere Lake in Northwich, which is kind of like a tethered, towed round by a wire. He's come off the end of that and gone into a rib which was parked next to the shore. With essentially, he's got what's called an isolated fractured femur. So he has 160 of ketamine off me, 100 of fentanyl, and a Kendrick traction splint.
Okay, so predominantly femur plus or minus a bit of something in the pelvis.
Yeah. If I had to put money on it, it's a mid-shaft.
Okay. We're just going to take the strap off your arms, okay? What's your name?
Toby.
Toby.
Trachea central, there is no chest wall tenderness, equal bilateral chest movement, equal air entry. Respiratory rate is around 18, and I'm waiting for the saturation to come up.
Okay, but he might be a bit cold because he's been in the water. Okay. Nice and steady, nice and steady.
You feel my touch here.
Can you wiggle your toes in your left foot for me? What about the ones in the right? You feel me touch you all right down there? Yeah, and on the sole of your foot and on the top?
Simon, 10:36:1.
Hiya. Hello, I'm Anthony. I'm in charge of the 3-ring circus that's currently revolving around you. We're going to take.
Scratch is coming.
I'm just going to jab your hand. We're going to get an X-ray of your pelvis here. We'll let that strapping around your pelvis a bit more loose, and probably then re-X-ray to make sure that there isn't a small crack in your pelvis. We can't see at the moment that then opens back up. You've probably broken your left thigh, so that's currently in a splint. We'll need to get some X-rays of that. So as we find stuff, I'll let you know. We'll probably end up shooting an X-ray of your chest as well while we're here.
What about the pelvis?
Pelvis, we'll see if that's broken or not.
What's the deal with that then, if it is?
That depends where and how badly. So it's a very wide range, pelvic fractures, from something that's life-threatening to something that means you can go home walking the same day. It's clear for X-ray, thank you. RAU. So his pelvis, for the most part, looks absolutely fine. What it has managed to catch is the top end of the fracture in his thigh bone. Very big split there. We just need to now make sure that we don't just decide that's all he's got. If it's a high enough energy injury to break the thigh bone of a young man, it's a reasonably high energy injury. So clearly, the prospect of having more than one injury is entirely possible. Toby, so we're going to loose this binder that's currently stuck around your hips. We're going to leave the splint on your leg for now. That pelvis X-ray, we've caught the top end of the break in your thigh bone on there. We just need to make sure you haven't done anything else. We could ideally do with log rolling, so I can just check his back.
Yep.
So what we have to do, Toby, is a little examination of your back. I'm going to need to prod your back all the way down. All right.
Why do we need to do this?
Because we need to examine your back, and I can't get at it right now. Okay. Might be a bit sore rolling you. We're going to try and move you as little as we can. Yeah. So the idea being is we're going to roll you like you're one big piece of wood
hopefully, all at the same rate. All on Mo's command then.
Okay, ready, steady.
Bring. Use this right hand to bring, get him up over to 90. That's it. Okay. Any pain? No. Keep talking to me. Good stuff. All okay?
Fine, yeah.
I think we're all right. Okay.
Okay.
On Mo's command.
Steady, back.
We're just going to ease you back now. Okay. Okay, we're done. That should be it for that. Okay. Not living your best life today, eh, Toby?
Get the drugs. Where is rack?
John, can you
TRA.
get some drugs?
Level 1 trauma, head-on collision, no blood pressure.
Okay, let's just let that relax a little bit now. If they've got a spot in theatre, they may just take you straight to theatre from here, depending on how you are. So I need to repeat his pelvis x-ray now. The pelvic binder has been loosened. That can sometimes mask fractures. If there is an unstable fracture that then opens and begins to bleed, the patient's pulse will go up, the blood pressure will come down, and it'll sort of declare itself in terms of the physical signs on the patient. You hope for the best, but you prepare for the worst all the time, because it's not safe to not do that to a degree. Yeah, it's a nice, neat fracture. That'll be all right.
Is that the only fracture he has?
I think it is. I think he's got away with just the break my leg where I've hit the boat. Thigh bone fracture, fundamentally. Oh, yeah. All we can find is the thigh, so that's good. We haven't got several other things. I can sit you up a tiny wee bit and bend you up a little bit at the waist and see if that makes life more comfortable or worse, so let me know either way.
Yeah, let's give it a try.
Okay. And you've got family here now, so I'll hold it at there, just for 10 seconds, let you get used to it. Are you happy if I go and have a chat to them and then I'll bring them in to see you? Is that all right?
That would be wicked.
Yeah? Okay. Hang tight them in and we'll get back to you.
I did a trick and ended up in the side of a boat, which was parked stationary, and yeah, it's not gone well for me.
He's up in here in the resus room. That's not him, you're all right. He's here a bit more awake. I'll give you a couple of minutes with him, all right? If you need anything, just give me a yell, all right?
It's not bad.
I don't think it's as bad as I thought.
No, it isn't. It isn't. Did you hear it snap?
Yeah.
Ooh. They got you out straight away, didn't they?
They got me
Adam
out,
said they were in
yeah.
the water. Did they?
I'll hand it over to orthopaedics. They might be able to fix this today if they've got the right surgeons in and what have you. And he'll go back to just doing what he was doing, really. From his point of view, it's certainly not a great day at the office, because it never is when you break your thigh bone. And from our point of view, it's a, moderately sized trauma that we know we can fix and we won't lose a patient, so it's win-win, so that's great.
Knock, knock. Oh, hello. Ah, you're seeing. Cardiology is seeing him. Asia, what have we got free now then? Have we got one free? That 6 is free. The final outcome of the patient's journey is unpredictable. But I'm always in awe at what Mother Nature can do. Mother Nature's been along longer than what doctors have been around, and her ability for the body to recover after any illness or event is astonishing.
All right?
Yeah. Really good. Yeah? Yeah. Fine.
Right, we'll turn towards Annabelle as we turn. Well done.
Thank you.
Feeling okay?
Yeah, I'm feeling really good. I can't believe how well I do feel, considering what I've been through. But
I said, I can't thank you enough for what you've done.
Not at all. How many walks have you done now up and down this?
3 now, including Nancy. Yeah, but I've done more by my bedside, so sort of been jogging on the spot sort of thing. It's quite astonishing, really, for what's been sort of done to me. But yeah,
Come back to me tomorrow once you've had the trial. You're doing fine. So good luck with the scan. I hope all goes well. But
thank you.
I couldn't be happier, really.
Thank you very much.
Well done, mate.
It's overwhelming, and it's amazing what the surgeons can do these days. Because if you had something like this years and years ago, you wouldn't survive it. So to do what he's done has given my life back.
"18-year-old male, 15 minutes away, multiple stab wounds to the arm and chest."
Yes. He's been stabbed in his right bicep and then 5th intercostal space posterior on the right side.
Anyone who's involved needs to have lead on because we're doing immediate x-rays, please. We're getting a full trauma team. We're booking him in. We're making sure blood is available for him. Sorry, sir, I'm just going to cut you off. This might be a bit not pleasant.
Got a left-sided head injury with swelling.
There's a lot of blood on the sheet. The priority is to get his airway sorted. She's got pain across her back, down her left leg. She's got what looks like an open femur fracture. She's then got an open left-sided ankle fracture.
There is a small chance that we give you a neurological problem that you didn't start off with.
There's deep bleeding from somewhere I can't see where it's coming from.